Part 19A, normal coronary perfusion. Now we go to points 16 to 20, which, as we said, will look for signs of ischemia or infarction in the topographic leads of the ECG. What are these topographic areas? They can be summarized in the mnemonic SALIP. These are the septal, anterior, lateral, inferior, and posterior leads or areas of the heart. The leads of the septal or right ventricle are leads V1 and V2. The anterior leads are V3 and V4. The lateral leads are V5 and 6, as well as leads 1 and augmented VL. The inferior leads are leads 2, 3, and augmented VF. And finally, the posterior leads are V7, 8, and 9. Let's explore a visual way to remember which coronary branches coincide with which leads on the ECG. An easy way to look at this is by superimposing the anatomy of the coronaries on the ECG paper itself. Sounds silly, but bear with me. Well, if the aorta gives out a right coronary and a left coronary, right? The right coronary runs to the right side of the heart, and the left coronary divides into the left anterior descending, known as the LAD, which runs down the middle of the anterior surface of the heart, and the left circumflex artery runs around the lateral left side of the heart, right? Let's imagine the ECG paper is the anterior surface of the heart. So if the coronaries are running down from the top of an ECG paper, the right coronary will run down the limb lead side of the paper and supply the lower limb leads, leads 2 and 3, and the left anterior descending will run down the middle of the ECG paper and so supply the anterior chest leads, V3 and V4, while the left circumflex will run around down the lateral chest side of the ECG paper to supply the lower lateral leads, V5 and V6. So the right coronary supplies the inferior surface of the heart, which is monitored by limb leads 2 and 3. The left anterior descending supplies the anterior surface of the heart, which is monitored by the chest leads V3 and V4, while the lateral circumflex supplies the lateral surface of the heart, which is monitored by the lateral leads V5 and V6. Now, what are these leads trying to detect? What are we looking for in these groups of leads? Well, we are looking for abnormal patterns in the Q wave, or the ST segment, or the T wave. But first, let's see some definitions. Let's start with the Q wave. The Q wave is the first negative wave in the QRS complex. The R wave is the first positive wave in the complex, and the S wave is the second negative wave in the complex. Regarding the Q wave, there are certain criteria to make sure the Q wave is normal and not pathological. We will discuss these in the next part. Part 19C, analogy for the Q wave. To understand the Q wave, let us reimagine the chest leads as 6 cameras inside a classroom. The 3 right chest leads, V1 to V3, are cameras on the right side of the room, and the 3 left chest leads, V4 to V6, are cameras on the left side of the room. In the middle of this room are 2 rows of people representing the right and left ventricles. 4 school children wearing green represent the right ventricle and septum and are facing the right cameras. And 6 teachers wearing blue representing the left ventricle are facing the left wall's cameras. So if everyone is standing still, what are the right cameras seeing at this point? The cameras V1 to V3 are seeing the faces of 4 children in green and also seeing the backs of the 6 teachers in blue. What are the left cameras seeing? Well, the cameras V4 to V6 are seeing the faces of the 6 teachers in blue and the backs of the 4 children in green. Now, what if, at this point, the children start walking towards the right cameras on their side? Okay, so what will the right cameras see? The right cameras will see the children moving closer. So if the cameras were electrical leads, they will draw the approach of the children as a positive wave. At the same time, the left cameras will see the children moving away. So if the cameras were leads, they will draw the children's movement as a negative wave on the ECG. Now let's ask the teachers to move at a slower speed after the children and towards the left cameras. The right cameras will see the teachers moving further away, so they will perceive the teachers in blue as a negative wave. At the same time, the left cameras will see the teachers moving closer, so they will draw the teacher's movement as a positive wave. So what did the right cameras draw? The right cameras V1 to V3 drew the children's movement first as a small positive or R wave, and then the teacher's movement second as a large negative or S wave. And what did the left cameras V4 to V6 perceive or draw? They perceived the movement of the children first as a small negative or Q wave, and then the teacher's movement as a large positive or R wave. That is why in the right chest leads V1 to V3, the first move of the children or wave of the right ventricle should be positive and small, and the second move of the teachers or the wave of the left ventricle should be negative and large. While in the left chest leads V4 to V6, the first wave of the children or the right ventricle should be negative and small, and the second wave of the teachers or the left ventricle should be positive and large. So according to that, there should not be any Q waves in rightmost chest leads, and Q waves can appear normally in the left chest leads, but these left lead Q waves should be small as the children were small in the analogy and should be fast as the children are fast. So in the left leads, we compare the Q wave with the R wave in the same lead. The Q wave must be a small fraction of around 25% of its R wave, both in time and intensity. So it should be very fast, or about 25% of the normal QRS width, and it should be very small, or about 25% of the R wave in the left leads. So to summarize, the appearance of the Q wave in the right leads is pathological. The appearance of large Q waves in the left leads is pathological, but the appearance of small Q waves in the left leads is actually normal. Is that clear now? Great. Let's now move to the next part, Part 19D. 19D, S segment and T wave. So now we will look for the ST segment abnormalities. But first, what is the normal ST segment? It should not be above or below the isoelectric line. But which line is the isoelectric line, you ask? Well, it is the line on which the P wave is resting. That line is your baseline level or isoelectric line. If the ST segment is below this line, that could indicate ischemia, especially in topographic distributions. If the ST segment is above this line, that could indicate STEMI or ST elevation myocardial infarction. This is especially significant when it occurs in contiguous leads, which are several leads in the same topographic group. So is any height of ST elevation significant? Well, one small square is enough to be significant in most leads, but there are exceptions. One small square is enough, except in the most anterior and the most posterior chest leads. So in the most posterior chest leads, V7, V8, and V9, even a smaller elevation of half a square above the isoelectric line warrants attention. While in the most anterior chest leads, V2 and V3, we need more elevation than one square to indicate significance. Why do you think there is that difference between anterior and posterior leads? Well, the posterior wall of the heart is deeper in the mediastinum, so if small ST elevations were able to appear on the ECG from that depth, that is probably a more serious pathology. On the other hand, the most anterior topographies are closer to the skin, so we require a higher level of significance in the ST elevation, or let's say a higher trigger value, to catch our attention than the average elevation of one square. So generally, in the V2 and V3 leads, if it is more than 2 squares for males or 1.5 squares for females, then we consider it a significant ST change. Another important point is the point of reciprocal changes. For instance, we generally do not ask for the posterior leads in the 12-lead ECG, but let us say that we see changes in the anterior or lateral leads, and let us say the change is an ST depression, then we should ask for posterior leads to be done. It is true that the ST depression in anterior, lateral, or inferior leads can be a sign of anterior, lateral, or inferior ischemia, but it can also be a reciprocal mirror of a more serious condition in the opposite area of the heart, like a posterior ST elevation myocardial infarction. So the SDT depression in some leads can mean a reciprocal ST elevation in the opposing leads on the chest. T waves can also show changes. T wave inversion can occur in ischemia, while hyperacute T can occur with ST elevation, myocardial infarction, and with hyperkalemia. So we need to look for abnormal Q waves, abnormal ST patterns, and abnormal T wave patterns in all the topographic areas following the mnemonic SALIP. Septal and right leads are V1 and V2. Anterior leads are V3 and V4. Lateral leads are the chest leads V5 and V6, and lead 1 and augmented VL from the limb lead. Inferior leads, which are leads 2 and 3 and augmented VF. Then we generally reserve posterior leads, which are the chest leads V7 and V8 and V9. If suspicions arise due to anterior, lateral, or inferior lead abnormalities, in a case of suspected coronary ischemia, in addition to looking for STT changes in the ECG, we also ask for cardiac enzyme. This is to differentiate the three main types of acute coronary syndrome. These help either to confirm STEMI and non-STEMI, or to exclude cases of unstable angina which have abnormal ECG but normal cardiac enzyme. The first cardiac enzyme is CKMB, which appears faster in the blood at about 3 hours, but disappears faster as well at about 30 hours. The second cardiac enzyme is troponin, which appears a bit later in the blood at about 5 hours, but can be found in the blood for more than a week. It is important to understand that diagnosis of ischemia or infarction is not just an ECG diagnosis, but is also a clinical and laboratory diagnosis. Whoa, that is a lot of information. Well, anyway, good luck.